Hello, and welcome to Osteoarthritis Action Alliance Lunch and Learn webinar for October 18th, 2023. Thank you for joining us this month. Our presenters today are Jeff Driban and Jackie Whittaker. Jeff Driban is a professor in the Department of Population and Quantitative Health Sciences at the UMass Chan Medical School. His research explores novel risk factors, biomarkers, and imaging markers to facilitate more efficient clinical trials and a better understanding of osteoarthritis, pathophysiology, and potential endotypes and phenotypes. Jeff also aims to raise awareness about osteoarthritis and promote primary and secondary prevention strategies. He is chair of the Osteoarthritis Action Alliance's Secondary Prevention Task Force. Dr. Jackie Whittaker is an associate professor in the Dept of Physical Therapy at the University of British Columbia and research scientist at Arthritis Research Canada in Vancouver, Canada. She holds a Michael Smith Foundation for Health Research Scholar Award. As a recognized clinical specialist in musculoskeletal rehabilitation and clinical epidemiologist, her research takes a lifespan approach to preventing osteoarthritis, with a particular emphasis on post-traumatic knee osteoarthritis. This includes reducing the burden of sports-related knee injuries by improving our understanding of the long-term consequences of knee injuries and developing and evaluating exercise-based interventions to promote knee health. Central to our research is an integrated knowledge translation approach involving patients, health professionals, and other stakeholders throughout the research to practice continuum. Recently, Jackie co-led an international consensus called OPTIKNEE, which produced 7 meta-analyses and consensus recommendations related to preventing OA after traumatic knee injury. Jackie's research is guided by 21 years of clinical practice and has resulted in over 90 peer-reviewed scientific publications. The title of today's presentation is Playing the Long Game, Consensus for Preventing Osteoarthritis After an Anterior Cruciate Ligament Tear. Jackie, I'll toss it over to you to get things started.
Perfect. Well, thank you for that introduction. And thank you also to the Osteoarthritis Action Alliance for the opportunity to be here today and for giving myself and Jeff the opportunity to talk about the long game after knee injuries, and in particular, the 2 consensus processes that we have had the opportunity to be involved in over the last several years related to preventing osteoarthritis after knee injury. And I've gone with knee injury instead of ACL injury. You'll see why. It is very much about ACL injuries, but we weren't sure it was just about ACL injuries when we started, which is why I've just gone a little bit broader, but you'll see where it all comes back to. So our plan for today is to start by setting the stage through sharing some facts about post-traumatic knee osteoarthritis, and then just briefly explaining what a consensus is. And after that, I'm going to share the OPTIKNEE consensus with you, and then Jeff is going to share the Osteoarthritis Action Alliance consensus. And then we're going to open it up for some discussion and some questions. So first up, why should we care about osteoarthritis? Well, we probably already all know this. Put quite simply, we should care about it because a lot of people have it. And because we have no cure, it is one of the fastest growing health conditions in the world. So a lot more people are going to develop it. And in particular, a lot more people are going to develop knee osteoarthritis because that makes up about 80% of the cases. Now, this increase in osteoarthritis that we're experiencing has massive implications for individual citizens, but also cumulatively on us as a society as a whole. At an individual level, osteoarthritis can lead to pain, inactivity, and a variety of different things that ultimately reduce our quality of life and even increase our risk for premature death. From a societal perspective, osteoarthritis drives healthcare costs, it reduces overall workforce productivity, and it impacts our gross domestic products. Now, given that there is no cure for osteoarthritis, the only thing that we can do to reduce the burden is to stop it from happening or to prevent it. How do we do that? Well, osteoarthritis prevention could involve many different things. Perhaps the most obvious way to reduce the problem would be to improve function, reduce pain and symptoms and disability in people living with osteoarthritis. But we could also take things a little bit further and try to find ways to halt or delay the onset of osteoarthritis in people that are at increased risk. Or we could try to prevent exposure altogether to risk factors for people that are susceptible to being exposed to risk factors. But however you look at it, osteoarthritis prevention is about being able to identify and then modify or mitigate risk factors. So what are the big risk factors for knee osteoarthritis? Well, one of the most established ones is a knee injury. And in fact, about 50% of people that have a knee injury, a significant knee injury, will go on to develop osteoarthritis within about 10 years. Now, given that knee injuries are most common between the ages of 15 and 35, this means that these people develop osteoarthritis by the age of 40 or 45, so much younger than we would typically associate with osteoarthritis. And that means that these people are going to live a good proportion of their adult lives with pain and disability, which could interfere with their work, their recreation, parenting, and their health. Now, knowing that 50% of people who have a knee injury will develop osteoarthritis actually presents us with an opportunity to either halt or delay the onset of osteoarthritis, or at least reduce the severity of future osteoarthritis. But despite knowing about this opportunity for some time, the prevention of post-traumatic knee osteoarthritis hasn't really gained a lot of momentum. And some of the big reasons for this lack of progress is that to really exploit this opportunity, we need to know who gets post-traumatic knee osteoarthritis, so we know who to target. We need to know why they get it, so we know when and how to intervene. We need to know what to monitor, so we know if our interventions are effective. So what can we do to move the field of post-traumatic knee osteoarthritis prevention forward? Well, that's where consensus comes in. So a consensus is a formal process that we can use to create agreement around a topic when there is either limited or no evidence to guide our decisions. Examples could include situations where we need to define or streamline something, when we need to set priorities, or when we need to determine the best way to act. So in a healthcare setting, this might include figuring out the best way of delivering care for a particular group of patients. To put it another way, a consensus is about providing guidance to a field that needs a spark. And it involves basically three things: developing items, and those items could be recommendations, they could be statements, or they could be definitions. It really depends on what the questions are. And those items are based on what we currently know. We then measure the current level of agreement for these items after we've generated them. And for those where we don't really reach a lot of agreement, we talk about them as being dissenting viewpoints, and we gather those and we report them. So contrary to its name, consensus is not about everyone in the room agreeing. And in fact, dissenting viewpoints, as I just mentioned, are actually a really important part of consensuses, and they help us to figure out the way forward. And in that way, consensus statements should not be seen as an endpoint. Rather, they're a summary of our current understanding of a topic, which in time we know will evolve as more knowledge becomes available. Now, I'm not going to get into the details about different approaches to consensus. There are essentially four main types or methods, and each has their own unique indications, features, pros, and cons. With that said, there are some generic steps. Typically, they start with a small group of people who identify a mutual problem or a topic where there's some inconsistency. This group then develops some guiding questions and identifies a larger expert group. Once the people are in place, then the first big task is synthesizing the existing evidence on a topic to understand what's known, the certainty of that knowing, and what's unknown. The group will then generate consensus items. So again, that might be a statement, a recommendation, or a definition. And that items are going to be based on the evidence that they found, and where that evidence was lacking, expert opinion. Consensus items typically undergo a series of revisions. Sometimes there's a credibility check with other stakeholder groups like patients, and then they're voted on by the experts, and the level of agreement and any dissenting viewpoints are captured. Now, the last thing that I want to mention about consensus is the concept of an expert, or who's going to be in the room, who's going to fill in the knowledge gaps, and who has a vote. Essentially, an expert can be anyone with comprehensive knowledge or skill in a particular area, including people with lived experience. So quite commonly in a healthcare setting, that will include patients as well as the clinicians that deliver care. The goal when deciding upon the expert group is to include people that are credible and bring diverse viewpoints, because there's evidence to suggest that consensus items that incorporate credible and diverse viewpoints are more likely to lead to that spark or that desired change. So just to summarize, knee joint injuries are an important osteoarthritis prevention target. However, to take advantage of this, we need to know who to target, when and how to intervene, and what to monitor. Consensus is a process that we can use to summarize what we know on a topic and agree on a way forward until more evidence is available. And finally, the outputs of a consensus include items, level of agreement of those items, and dissenting viewpoints. All right, so keeping that in mind, I'm going to introduce you to the OPTIKNEE consensus. So OPTIKNEE began in 2016, really as conversations between colleagues in Canada, Denmark, and Australia related to combining data sets to guide post-traumatic knee osteoarthritis prevention. We did a bunch of preliminary activities between 2017 and 2019, and then it was really in April of 2019 when things got kicked off, and we held a planning session prior to ORCE that was held in Toronto that year, where we invited 35 individuals, including researchers, clinician scientists, people with lived experiences, and actually health charity representatives, which this, as I said, really served as our kicking off point. The broad goal of the consensus was to develop evidence and consensus-based recommendations for optimizing knee health after injury to prevent post-traumatic knee osteoarthritis. And this included recommendations to guide clinical practice as well as future research. Over the last several years, our large group of clinician scientists, researchers, and patient and clinician partners has conducted a 7-step consensus exercise. Now, I don't want to bore you with all the details, but I do want to quickly highlight the questions that guided our work, the evidence syntheses or the systematic reviews we produced, and how the recommendations were developed. So as far as guiding questions, we really had 4 to focus our work. We wanted to know who develops post-traumatic knee osteoarthritis and why, the long-term consequences of traumatic knee injuries, the best management and treatment strategies to optimize knee health after injury, and the most important outcomes to monitor knee-related health. The first step to answering those questions was to summarize what's currently known based on the existing research. So for us, that meant performing 7 systematic reviews spanning the concepts of traumatic knee injury burden, risk factors for post-traumatic knee osteoarthritis, treatment for symptoms and treatment for structure after knee injury, and how to monitor health status with patient-reported outcomes and outcomes of strength and function. To understand how confident we could be in the existing knowledge, we also assessed and reported the overall certainty of the evidence that was contained in the information in each review. In the end, we sifted through just over 27,000 papers and ultimately synthesized the findings from about 230 original studies. The second step to answering the questions was to take what we learned from the reviews, map it back onto our guiding questions, and identify if there was any remaining knowledge gaps. Then we turned back to our expert panel to fill these knowledge gaps before finalizing our recommendations and voting on them. As far as voting, we used a 9-point scale where a score of 1 to 3 indicated that the recommendation was inappropriate, a score of 4 to 6 was that the recommendation was of uncertainty, and that a score of 7 to 9, was deemed as it being an appropriate recommendation. A more detailed description of our methods, the recommendations, the results of all the agreement voting, and all of our dissenting viewpoints are reported in the consensus paper, which along with 6 of the systematic reviews were published in the OPTIKNEE edition of the British Journal of Sports Medicine at the end of 2022. In the end, we presented 7 consensus definitions, 8 clinical recommendations, and 6 research recommendations. We also summarized a variety of dissenting viewpoints. The definitions are related to core concepts about knee injury, knee trauma, and knee osteoarthritis and prevention that can be used to facilitate discussions on the topic area. The clinical recommendations are related to those questions of who, when, and what to target, what to do, and what and how to monitor to prevent post-traumatic knee osteoarthritis, while the research recommendations outline best practices for study design and make suggestions on how to harmonize outcomes to facilitate future data syntheses. Now, I am going to briefly present the clinical and the research recommendations in a second, but I also want to mention that we've developed 1-page summaries, which I know you cannot see on the screen because they're way too small, And we've actually translated them too. We've got an ongoing translation process going. I think we're up to 8 languages now beyond English. And they can be accessed through the QR code or actually the link that Nicholas has shared in the chat. So if we start with the clinical recommendations, the recommendation about who to target to prevent post-traumatic knee osteoarthritis is people with single and multi-structural injuries of their knee, particularly those that have torn their anterior cruciate ligament or meniscus, or had an intra-articular fracture or dislocation. And priority should be given to people with symptoms and/or functional deficits that persist beyond usual recovery times, or who've had a subsequent injury, which would include surgery. So in a practical sense, this means that everyone with a knee injury should be made aware of their elevated risk, and those at highest risk should be taught how to manage that. As far as what and when to target, the recommendation is to promote knee health through education and exercises aimed at mitigating known modifiable risk factors for re-injury and non-traumatic osteoarthritis, such as knee muscle weakness, inactivity, and weight gain, using an approach that is person-centered and builds capacity for self-management. And ideally, these efforts would start early after injury and continue indefinitely. So in a practical sense, this means that you need to work with a patient to identify and address their needs for information about their knee health and osteoarthritis, and then guide them to use exercise and physical activity to avoid or address muscle weakness, inactivity, and weight gain. And knowing that the first 2 years after injury is key, we would want to start these efforts as soon as possible and then encourage them to continue them indefinitely, which is where that self-management piece comes in. With respect to what to do after an ACL tear, which I mentioned is one of our main target groups and was actually the title of this presentation, the big take-homes are that the first-line treatment should include education and exercise-based rehabilitation, with the option for a surgical reconstruction as needed. Rehab should be goal or criterion-based and culminate not just in return to sport or activity, but set the patient up to be able to self-manage their knee health long-term. And core components of rehab include progressive resistance-based programs that target both open and closed-chained activities of the lower extremity and incorporate neuromuscular control and eventually activities to build power, muscle power. With respect to what to monitor, core outcomes include knee-related pain and symptoms, cognitive behavioral factors that influence learning and performance, like fear and anxiety, physical function measured both self-reported as well as muscle function and performance outcomes, quality of life, and physical activity in sport. Other important outcomes can include body weight, health-related quality of life, participation in social roles and responsibilities and relationships, and injury-related mental health. So remember, these recommendations are for clinicians. Finally, diagnostic imaging is only indicated when the results will inform treatment planning. There are also specific recommendations on what patient-reported outcome measures to use to measure these various outcome domains based on our rigorous evaluation of their measurement properties, as well as recommendations on how to monitor muscle function and functional performance with a variety of different approaches and methods depending on your setting. The last clinical recommendation provides guidance for how to interpret patient-reported strength and functional outcomes, and this recommendation is really grounded on the concepts of differentiating treatment failure from patient-acceptable symptom states. I'll also just mention a few of the dissenting viewpoints related to the clinical recommendations, and those were how to operationalize the decision that a patient who has torn their anterior cruciate ligament has completed sufficient rehabilitation and should consider reconstruction surgery, the value of bracing early after surgery to either restrict motion, promote weight bearing, or temper fear or anxiety related to movement, and the feasibility of using single domain patient-reported outcome measures, multiple HOP tests, and formal muscle testing in clinical settings. As far as research, the recommendations address prioritizing symptomatic knee osteoarthritis over structural osteoarthritis, reaching consensus to enable data syntheses, and understanding the role of social determinants of health the social determinants of health on long-term outcomes after a knee injury. There are also recommendations related to best practice for study design and to encourage research beyond the consequences of anterior cruciate ligament reconstruction, So that means including participants that are ACL deficient or who have non-ACL tear-related injuries, particularly fractures and dislocations. And ideally, we would like to see more studies that have follow-up beyond 5 years. Finally, there's recommendations about what outcomes to monitor and how. And again, these span the categories of patient-reported outcomes, muscle function, and functional performance outcomes. So just to summarize, the OPTIKNEE consensus used a rigorous and transparent approach to develop evidence and consensus-based recommendations to improve health-related outcomes after knee injury with the goal of preventing post-traumatic knee osteoarthritis. The recommendations can be used to increase awareness about and advocate for preventing the long-term consequences of knee injuries. More specifically, the clinical recommendations can be used to guide clinical practice to improve health outcomes after knee injury, while the research recommendations can be used to develop, test, and implement evidence-based interventions and facilitate data syntheses to better understand and hopefully ultimately reduce the burden of knee osteoarthritis. So I'm going to leave it there. I'm going to stop sharing my slides and turn it over to Jeff. Jeff, just making sure you're unmuted. Oh, there you go.
There we are. Yes, thanks, Jackie. Thanks for that great setup for why we're doing consensus statements in this space and for the overview of OPTIKNEE. In regards now, I'd like to talk a little bit about the Osteoarthritis Action Alliance's consensus statement, give you a little bit of a background on how we went about developing our consensus, and then what our recommendations were. So our process started back in 2020 as a result, in part as a result of the National Athletic Trainers Association's review of the National Public Health Agenda for Osteoarthritis, which they were considering for endorsement. During that process, they had noted that the public health agenda lacked any discussion about secondary prevention of osteoarthritis after a knee injury. And our response was that while there may be a consensus within the field for what to do for people after a knee injury, there is not sufficient evidence for inclusion in the public health agenda. And so that kind of sparked our discussion about developing a consensus statement. And so in the summer of 2020, we had an initial meeting to develop our goals. And then in the fall, we had another meeting to refine the key topics we wanted to focus on. Then in the late fall, early winter of 2020-21, we divided into 9 subgroups that initiated the writing process for drafting the recommendations and the supportive narrative text that would justify those recommendations. In January and February of 2021, we initiated our first round of voting. And then we went through 2 more rounds of voting, including having another meeting where we kind of worked to harmonize the text a little bit before having our final vote. We then spent several months harmonizing the text between the different groups, asking people who had dissenting opinions to offer a paragraph or 2. And then we asked the task groups to review their updated text. And we asked for full approval from the task group as well as the OA Action Alliance Steering Committee. The papers were published in May 2023 by the Journal of Athletic Training. Over the next few years, we'll be focused on disseminating and resource development. And we proposed in the papers that within 5 to 10 years, the recommendations should be reassessed and a revision considered. When we initially met in 2020, we decided that our goal was to provide clinicians with secondary prevention recommendations that were meant to reduce the risk of osteoarthritis after a person has an ACL injury. We also wanted to provide insights into areas that need more research. To initiate the recruitment process, we sent out an electronic invitation to the OA Action Alliance Steering Committee and Primary Prevention Task Group. This included representatives from AMSSM, Arthritis Foundation, Osteoarthritis Research Society International, U.S. Bone and Joint Initiative, and several other organizations. We also encouraged all of the recipients to share the invitation with other contacts. Ultimately, we had 29 members, 24 members from 18 different institutions within the United States. We had 4 Osteoarthritis Action Alliance staff members and 1 member from Finland. The group included athletic trainers, physical therapists, psychologists, orthopedic surgeons, and sports medicine physicians. During our initial meeting, we agreed that our target population would be people up to the age of 40 years. This would include the majority of people who experience an ACL injury, but it would also make them less likely to have osteoarthritis at the time of the injury. We also said that we wanted to target people from the time of their ACL injury until they've developed knee osteoarthritis, which at that point, they could potentially refer to osteoarthritis treatment guidelines. It's important to acknowledge that this time frame includes essentially 2 unique periods. One is the first year after an ACL injury, when people tend to be actively engaged in the healthcare system through rehabilitation, potentially surgery, and then clearance for return to activity. But it also includes this period where after they've been returned to activity until they've been diagnosed with osteoarthritis, which is kind of a lost decades of care. Because while many patients may still be experiencing symptoms, they're not engaging with the healthcare system about those symptoms. During our initial meetings, we also declared our short-term and midterm goals for clinicians. The first was to promote a patient's role in shared and informed decision-making around their care. We also wanted to educate people about their injury and recovery, such as what to expect, what are their long-term risks, and how can they modify them, coping strategies, maintaining or improving self-efficacy, the importance of adhering to what they're doing, stress management, and goal setting. We also wanted to optimize physical activity for each individual, for example, trying to return them to previous activities or activity modification to help ensure that they're remaining physically active. We also wanted to prevent or reduce chronic symptoms, including knee pain, poor quality of life, functional limitations, and fear of re-injury. We also aimed to try and prevent subsequent injuries, and we wanted to try and reduce the psychological stresses associated with recovery, such as related to return to activity or communicating with clinicians. So we drafted our recommendations in supportive text in the 9 subgroups. We had 22 out of our 29 members participate in our first round of anonymous voting. During that time, individuals were asked to provide feedback to the task groups on how they could potentially update the recommendation and supportive text to get additional support. The task groups were then sent back to revise the recommendations and supportive text. We then completed a second round of anonymous voting where all but one of the people who participated in the first round participated in the second round. Again, the individuals who voted against the recommendation were asked to provide recommendations for how to revise the text. After this round, it was decided that there was some conflicting information being sent back to the subgroups. And so we had a virtual meeting to review the wording and provide final votes. During this call, we asked that the groups that were working on the psychological interventions reframe and revise the recommendations. And then we completed our third round of voting, where everybody who voted in the second round completed the third round. We then had 3 authors that helped harmonize all of the documents from the different subgroups. We also sought out dissenting opinions, put them all together, asked for the full task group to agree to it. The document was also sent to individuals who were not involved in the voting process, but part of the initial startup, and they served as a final review from the task group. We then submitted the consensus statements and evidence review to the OA Action Alliance Steering Committee for final approval. Ahead of time, we had defined that having more than 80% of voting members would represent a consensus. As I already mentioned, if a person had a dissenting opinion in the first or second round, they were asked to provide those recommendations to the subgroups. And in the third round, if somebody still was not supportive of a recommendation, then we invited them to write a dissenting opinion. And if we had more than one individual writing a dissenting opinion, we worked with them to harmonize the text into a paragraph or 2. Our initially, we had 16 recommendations related to patient resources and education, rehabilitation programs for safe return to activity, psychological well-being, regular physical activity participation, assessments and monitoring, patient support programs, use of technology to support recovery, and all of them achieved a consensus except for cognitive behavioral counseling, which fell 1 vote short. What I'm going to do now is introduce these in a little bit more detail based on an infographic that we have developed for the consensus statement. And the resources, the consensus statement, and the infographic that you'll see in a moment are available on the link you see below, and we'll have this link on our last slide as well. So a big portion of our recommendations, about the first 3 or so, focused on optimizing education. We wanted to focus on preserving wellness after an ACL injury. And to do so, we wanted to improve patient knowledge about the risk of poor outcomes after an ACL injury. We also wanted to seek tailored education and tools to facilitate communication with patients and caregivers about osteoarthritis and prevention. And we recognize that this can't be done at just a single time point. We encourage people to have these discussions and to try and educate patients throughout the recovery process, both at the time of injury and other intervals throughout. We also acknowledged within the consensus statement that there may be a need to provide educational opportunities for healthcare providers on how to educate patients about this topic. And that could be done at entry-level education, but also through continuing education. We also advocated for a supervised, comprehensive, and progressive rehabilitation care that could address impairments and neuromuscular deficits, quality of movement, knee range of motion, quadriceps muscle strength and performance, and functional performance. We also advocated for gradually pursuing sport-specific training, encouraging people to meet the physical activity guidelines for Americans, 2nd edition, and offering psychological skills training or graded exposure therapy as needed. Psychological skills training can help foster focus, acceptance, and attentional control at decision-making and a mindful state through activities like mindfulness meditation, mental imagery, or goal setting. And these can be taught by various trained clinicians, including physical therapists and athletic trainers. We also advocated for implementing preventative training programs aimed at reducing the risk of future injury by focusing on exercises to improve strength, agility, balance, and flexibility with proper technique. And we acknowledge within the document that the Remain in the Game toolkit developed by the Osteoarthritis Action Alliance could be helpful in this regard. We also promoted team-based care, and that we acknowledge that in order to implement these recommendations and address patient needs, we might need interdisciplinary, coordinated, and patient-centered care strategies. We also want to encourage organizations to optimize socially supportive environments throughout the recovery process and to provide support for potential psychosocial stressors encountered during the rehabilitation process at home, at work, and during the return to activity process. These psychological stressors can be related to things like injury-related stigma, uncertainty about their return to activity, and threats to personal identity. And so we need to do more to normalize the rehabilitation process, for example, including the patient's peers in the rehab process. We also advocated for measurements and monitoring. Specifically, we suggested that it was important to regularly monitor patients using patient-reported outcomes, performance-based outcomes, and other indicators of progression. And in our documents, we offered tables of commonly used measures that are used in clinical settings, but also in research settings. We also advocated for a multifaceted return to sport test battery to inform a shared decision-making process when determining the readiness to return to activity. And this could include assessing quadriceps strength, performance-based measures such as hop tests, or patient-reported outcome measures of function. We also suggested that technology can play an important role in monitoring and educating people throughout the recovery process. So we need to consider both the ethics and the effectiveness of how and what technology is adopted for monitoring and prevention. It is important to acknowledge some of the limitations associated with this consensus statement. First off, these are not formal clinical practice guidelines because we lack high-quality evidence. So the recommendations are based on the best available evidence from the literature or personal experience. It's also important to keep in mind that the task group was predominantly based in the United States. So when we try to apply these consensus recommendations to other geographic locations, we need to consider how they may need to be adapted. For the next steps, we plan to continue to promote the consensus statement, develop more infographics. The first one was for clinicians, but we have plans to develop more. We also want to develop consumer resources for the patient. And to do that, we will have discussions with patients about what and when and how they would like to receive information. We also want to create educational resources to help healthcare professionals have these discussions with their patients. We also see the value of potentially creating a mobile application and offering insights on how to do a coordinated care program. We also want to seek out collaboration, such as this one today, with other consensus statements related to this topic, such as OPTIKNEE. In summary, we hope that we're providing clinicians with secondary prevention strategies intended to reduce the risk of osteoarthritis in patients after an ACL injury. We adopted a comprehensive approach to address physical and mental well-being, and we hope that we're fostering more discussion on how we can help ensure the long-term wellness of people after a joint injury, not just after ACL injury. We also want to spark discussion about what patients need to know to be informed consumers in a healthcare system. We also want to guide research because each of these recommendations still requires high-quality evidence to justify and refine the advice. Finally, we hope to raise awareness among clinicians and researchers and encourage them to take steps to reduce the risk of osteoarthritis after an ACL injury. I'd like to thank the task group who helped write the document, as well as the growing members that are joining us to help with the dissemination and implementation process of this recommendation. And at this point, I'd like to open up the floor for discussion, and here you can see links to both consensus statements. Thank you.
Thank you so much, Jeff and Jackie, for this presentation. It was wonderful. If anyone should have any questions, please put them into the chat, and I will read them out. I know while listening to it, I have a question for Jackie. It seems very, there's that, it almost appears like Canadian guidelines versus US-based guidelines. And I was wondering, Jackie, have you had any success stories so far embedding these OPTIKNEE suggestions into any medical systems, either in Canada or in the US?
So I would say these are definitely not Canadian recommendations. Our team was an international group with representatives from over 9 different countries. So I don't see them as just being Canadian at all. And in fact, the very fact that we had a conversation about and agreed upon that first-line treatment for ACL tears should be education and rehabilitation and not ACL reconstruction, I think is actually very indicative of our international members. In North America, in Canada, similar to the US, often the first course of action is ACL reconstruction. Sometimes it's preceded by a little bit of rehabilitation. But I guess my first point is I certainly don't see these as being Canadian-based recommendations. And I think that was actually some of the fun and some of the challenge that we had when it came to us getting together and having conversations. As far as successes, I guess what I would say is, although Jeff and I suspect both of the large groups that we've worked with, the majority of the members, as well as many others, would agree that these are important steps that we need to be taking to reduce the burden of osteoarthritis, to prevent post-traumatic knee osteoarthritis. We actually don't have any direct evidence that if we apply these recommendations, it's going to lead to a reduction of the prevalence of osteoarthritis. And so it's a little bit challenging when you're working with health systems. Obviously, the health systems in every country are very different. Obviously, there's differences in the health systems between Canada and the United States. But it's very hard for me to go to a health systems provider, i.e. our government, and say, we want you to invest X amount of money now for prevention, and we can estimate that this might save you this much money down the road in reducing the number of total knee arthroplasties or the number of people with less sick leave from work, etc. And so we really have the job of doing the research now. So I think the recommendations are a summary of what we know and common sense. I think it's awesome that we've got pretty good consistency, in all honesty, between what the OPTIKNEE group found and what the Osteoarthritis Action Alliance group found. I think that, you know, I don't think we even knew these two consensuses were happening at the same time. And the fact that we've come to very similar places, I think, is awesome, because I think it gives us a larger voice. But the long and short of it is we've got research we need to do now. And so the next big success is going to be getting funding for a large randomized control trial where we actually apply some of these things. See if we can change things that are or outcomes that are related to osteoarthritis and follow those people for a period of time to see if that happens. We're going to need to do that alongside an economic analysis before we're going to be able to really get our healthcare providers in Canada to buy into funding these sorts of things. I guess the last thing I will also say is that most of the care that we're talking about would be provided by, quote, allied health professionals, which I know in the United States, but also in Canada, that care occurs primarily outside of the healthcare system. So physiotherapists, athletic trainers, occupational therapists aren't necessarily covered by public health in Canada. We treat people based on insurance, very similar to the States. And so it's challenging to go to a healthcare system and say, hey, you need to start funding care that you haven't actually previously funded before and justify that new expense. I know that was a long conversation, a long answer, but I think it's a complicated question, but a really important question. So thank you.
Yeah, we had another question. When discussing the lost decades of care, where does offloading bracing come into the discussion?
I can jump in quick, Jeff, and then maybe you. So we looked at bracing so where it came out in our reviews was as it relates to treating symptoms and treating structural changes after an ACL tear. So these were the systematic reviews led by Adam Colvener and Peter Holm. And what we found was actually there isn't a lot of evidence to provide recommendations related to bracing. Most of the research looking at bracing really is related to sort of that acute phase, and it doesn't really look at its role in maybe reducing risk factors long term, although we found no evidence that load was a risk factor for post-traumatic osteoarthritis. With that being said, just because we didn't find the evidence doesn't mean that it isn't. It's just that evidence doesn't exist. And yet that's why actually I mentioned that one of our dissenting viewpoints, we had long conversations around the role of bracing because the evidence would suggest not to use it. It's not effective, but really where it might be effective has not really been looked at. So the answer to the question based on the evidence is we don't know what its role is, Karen. I think there's work to be done before we can answer that. Jeff, I don't know if you have a different perspective on that.
No, I agree with the comment about the bracing and the lack of evidence, but I think it's also important to acknowledge that it's also not just a lost decades of care, it's a lost decades of research, right? Because it's just a population that historically has fallen through the cracks. We know that probably about 1 in 3 patients after their ACL injury, if you look at them 1 to 6 years post-op, that they're still complaining of chronic symptoms. Some of them saying that it's unacceptable symptom state, and about 1 in 10 say their treatment failed them. But yet we haven't really explored much what to do for that patient population. And in fact, a lot of times what you find when you talk personally with these people is they'll tell you, well, you know, my knee swells up when I go for a run, so I've stopped running, or it's just something I deal with. You know, it's not something that they've reported to a healthcare professional. It's only when you have that direct conversation with them or you ask the right questions that you hear those complaints. And so I think that's part of the reason why in both consensus statements, education and informing the patient is so critical, because we need to get them to appreciate that those aren't the new normal. That's something that needs to be brought to people's attention so that we can figure out a care strategy for that.
Yeah, that's a great point.
For the next question we had is, how can we differentiate between osteoarthritis and post-traumatic osteoarthritis with radiographic imaging?
I don't think we probably can. I think it's actually very difficult to differentiate between, let's say, non-traumatic osteoarthritis and traumatic osteoarthritis. The only thing we can do is ask somebody who has osteoarthritis, whether that be defined based on structural features on imaging, or whether that be based on symptoms or a combination of structure or symptoms, as to whether or not they've had knee trauma in the past. And that's where, ACL injuries and ACL reconstructions are really helpful for us when it comes to designing studies and looking at a large enough segment of the population to look at this in, because they're fairly prevalent. But you can't differentiate, I don't think. Now, I'm not sure if there are, and there may be somebody on the call that's more knowledgeable, Jeff, maybe you, there may be some biomarkers that allow us to differentiate, some of the changes we're seeing in cartilage and bone and other structures of the joint years later after trauma versus not trauma. But to my best of my knowledge, I don't think that we can. And I think a lot of times when we say that somebody has post-traumatic osteoarthritis based entirely on them having a previous injury of trauma, we can't know for sure if their osteoarthritis is related entirely to that trauma, or whether it's related to other things. Whether there's a metabolic syndrome going alongside at the same time, whether there's other risk factors for osteoarthritis that are present, whether there's some sort of a genetic component that may also be contributing. And I think that's the challenge. And I think that takes us back actually to Jeff's point about the lost decades of research. It's so challenging to follow these people and to get funding to follow these people for 10, 15 years to really start understanding how we can pick apart some of these questions and get answers.
Yeah, I think Jackie summarized that really well. I don't think there is a way to differentiate them except for their history. And I think the part of the challenge to that is the group you would be comparing them to, the people without a known knee injury, probably some of them will have had an injury that they did not notice. And I think we see that a lot with like root tears. You'll sometimes find them on MRI, despite the fact that the person doesn't recall a discrete event that may have triggered it. So there are incidences where people could have a structural injury that they don't recall the injury, but yet here they are developing osteoarthritis. And I don't know if it necessarily helps us to differentiate their specific radiographic feature that helps them. I think the key here is addressing the current paradigm issues that they're having. And as Jackie said, reducing their risk factors that may contribute to the onset of symptomatic radiographic full diagnostic osteoarthritis.
And we just got another question. As someone who works closely with orthopedic surgeons, there's essentially no buy-in that extended non-surgical treatments for acute ACL ruptures are appropriate. Do you have any additional thoughts about best ways to partner with our surgical colleagues?
I'm sure Jeff and I are fighting over answering this question. Lisa, I'm going to assume that you practice in the States or in North America. I think that's probably a safe guess, but maybe not. I think it really depends. If you don't practice in North America, so for instance, if you practice in Scandinavia, there is complete buy-in, and orthopedic surgeons will often not want to see patients until they have completed a good round of rehabilitation and determined whether or not they're functionally stable or not in their knee. We also have a couple randomized control trials that really show that there are, and actually a good cohort study. Lynn Snyder-Mackler, I noticed that Lynn's name was on the list of people that contributed to the OAAA Action Alliance statement. Her and a colleague from Norway, May-Arne Risberg, have had a cohort study for years looking at outcomes for non-op approaches to ACL tears between Delaware and Oslo. I think at the end of the day, there's a group of people that might need reconstruction early. There's definitely a group of people that never need reconstruction. And there's a group of people that probably do quite well for a while and then may need something depending on what's going on in their lives. The challenge we've got in North America is that we're still, our orthopedic colleagues are still very resistant to the research, the body of research, high quality, rigorous research out there that shows that. And really, I think, are still functioning from a real biomechanical model, pathoanatomical model, where they really feel that they need to do the reconstruction to minimize, I don't know, some sort of excessive amount of translation in the joint or on the meniscus, which could lead to osteoarthritis. But there just really isn't evidence to support that, unfortunately. I don't know, Jeff, what your thoughts are on it, but I think at the end of the day, we've just got to keep communicating. We've got an opportunity to, work closely with these colleagues. They believe in what they're doing, and I think that's important. I don't think they're doing it because they don't feel that they aren't helping people. But I think, as with any new evidence and knowledge, it can often take decades to make it out there. And for whatever reason, North American, and I might also say, Australia, New Zealand orthopedic surgeons are quite resistant to this idea, which is why we really felt strongly that we needed that recommendation there.
Yeah, I think Jackie again summarized it really well, and I think one of the things we do need to do, even within our current structure in North America and Australia and New Zealand, is to ensure that our patients are making an informed decision about surgery. Because I've also seen it when I was still working in the orthopedic office, seeing patients that were shopping around, looking for the person who would do the surgery sooner and get the athlete back quicker. So some of it is educating the patient to ensure that they're making an informed decision about why they're doing what they're doing. So it's not necessarily making that initial push in the States or in Canada to drop the procedure altogether or to do the extended care first. But perhaps our first step is keeping sure that our patients are understanding why they're doing what they're doing, and that they do have an option, that there are other options out there that they can try before surgery, and the timing of their surgery.
It's a really great point, Jeff. And I think that's where both these consensus can really play such an important role. I mean, at the end of the day, the consumer, which is the patient, should be making the decision. And I think in both of our consensus statements, we really highlight that. Yes, they need information from other people, but ultimately the decision is theirs. It's not the surgeons, it's not the physiotherapists. And we need to make sure that they have all the resources they need to make a decision that's going to make the most sense for them. It's a really good point. Maybe they'll drive changes and drive in care.
Hopefully.
Mm-hmm.
Not seeing any more questions at this moment. Well, thank you so much, Jackie and Jeff, and thank you to everyone who attended today's presentation. In just a moment, we'll launch a brief satisfaction poll, and please answer those questions before you leave the webinar. And finally, we hope you will join us next month on November 15th, 2023 for our Lunch and Learn featuring Elizabeth Bowen and Tyler Lights from the CDC, who will be presenting a talk on arthritis. Thank you so much and have a great day.